So I was a GP in real GP land like you guys are in for 27 years, and I left that 2 years ago to come into eating disorders, which I knew nothing about. So blind leading the blind. It's been really interesting though, and you guys do the most of the work. So some truths, I'm going to really quickly through it, but not everyone with an eating disorder looks ill. Many of them have normal BMIs or even BMIs over 25. Affect anyone, and has a highest mortality rate of any psychiatric disorder. Both genes and environment play important roles. Early detection's really important, so referring young people really important. And it's more than just getting people to eat more. Because basically we're asking them to give up what's actually been a coping tool that's been helping them survive for the young people much of their lives. Who to screen? Honestly, I've just made up this list because I couldn't really come across too many guidelines, but young people, probably if I was targeting screening, it'd be teenagers and those in their early 20s, people who are losing weight, or signs and symptoms of starvation. People just seeing you about weight concerns, people with menstrual disturbance, GI symptoms, young people with type 1 diabetes who are clearly not using their insulin in the correct way, athletes, dancers, models, and people who've had bariatric surgery. Quite a few of them run aground. What I've really learned in the job is, being gentle and non-judgmental. It's really hard for people to talk about their eating disorders. There's a lot of stigma and they have a lot of fear and shame, and really hard to get to the nitty-gritty and talk about what's really going on in their lives. I've learned not to make any comments about appearance or weight. I very much don't talk about, you never use the word weight, talk about concerns about malnutrition and that their intake is clearly inadequate. Just that kind of thing. So a couple of, when you are screening or targeting screening, the Inside Out Institute is fantastic. There's an online tool that you can actually almost have up on your screen and do this questionnaire where people get to grade where they are from never to all the time. Fantastic. I prefer this, to be truthful, to what you guys would be more familiar with, just scoff. But hey, both, just one or other, be fine. So if those questionnaires do highlight some concerns, this is just a rough framework, questions to maybe then start asking in your gentle, non-judgmental way. Ask about what it is that they are actually having. Say, when do you first start eating? What time? What does, they say breakfast. So what does breakfast look like? So they get to describe their intake. And just check, so what's happening after breakfast. And so try and maybe ask them what they ate yesterday. Ask what their fluid intake's like. Compensatory behaviour is really hard to get people to be honest, but just say, normalise it. A lot of people will vomit. Is that something you do? A lot of people use laxatives. Is that something you're doing? Tell me about your exercise and diet pills and diuretics. Ask about menstruation, libido, physical symptoms. And then previous heights and weights. See, look at trends. Trends are, it's all important trends. Mood, self-harm, alcohol, drug use, and driving. Because if you've got a really severe eating disorder that no one's ever found out about or knows about, and they're driving, you want to just check in a really gentle way, how's driving going? Any near misses, brain fog, any fainting, dizziness at the wheel. You don't actually need to diagnose eating disorders. You don't need to say, oh, this is anorexia nervosa, or this is bulimia nervosa. You just need to know that something's up that's not looking right and that this might be an eating disorder. And you want to just, you're in the great position to gather information about behaviours. So once you've done all those questions, you're then going to, probably at a separate appointment, because you'd never do all this in 15 minutes, get them back and say, I've got concerns. Is that okay if you come back and we can examine you? And an examination is really around height, weight. Getting an accurate weight is really quite good because there's a lot of concealment of weights. People will try and leave all sorts of paraphernalia in pockets, so get them down to their basic light layer. Some practices I know have invested in a gown, or even just maybe having a set of scrubs that people can pop in and leave their underwear on, but get some scrubs on just to get rid of the jeans and the hoodies and things. Temperature, a lying and a standing blood pressure, but waiting 2 minutes, which I know is really difficult. Even in general practice, often the bed in the where the blood pressure cuff is completely separate, so really difficult to do this in general practice. Check for murmurs, signs of heart failure. You may notice a few incidental findings along the way of lanugo, salivary gland enlargement. Their hair and their skin may have changes. A squat test, just to see what their muscle strength's like, and bloods are kind of handy. So what I do every time I see someone, and I do basically that, is I'm asking myself, does this person need to go to hospital? That's the first thing. And so in general practice, even if you're monitoring someone who's under a specialist service, it's still up to you to send them to hospital when their obs are looking grim. So medical admission criteria for all the Auckland hospitals is pretty much standardised now. And this is not yet on Health Pathways, which is bad, but I've been assured it's going to be on it soon. So it's a really busy slide, and take a photo if you like. So Starship Hospital sees people under 17. We're really lucky in other regions it's PEDS is under 16s. So we're so grateful for Starship see now people up to 17. But once they turn 17, unfortunately it's adult admission criteria, which is a lot tougher. Most admissions are for restabilisation. So might have just been in overnight while their blood pressures and pulses normalise or their temperature comes up. Sometimes it's for weeks and weeks if it's for refeeding. But if admission's not required, then the next thing's if this is someone who's new to you, you might be saying, well, do I need to address any nutritional or electrolyte deficiencies, or do I refer this person to an eating disorder service? And how often am I meant to see them anyway? So if you're going to be thinking about nutritional and electrolyte disturbances, think about, well, do they need a nutritional supplement and like a Fortisip or an Ensure? So there's special authority criteria there for that. Supplements, if someone's got a really low BMI and their diet's looking pretty inadequate, I will often be prescribing some thiamine, some B-complex vitamins, some multivitamins, magnesium potentially. I might also be guided by blood levels for that. If they're vegetarian and vegan, and I think 100% of my clients are, looking at oral iron and oral B12 supplements, bloods will help guide that. Quite a lot will need some Ferinject, because no matter how much oral iron I give them, they don't seem to need, their ferritin stays really low. Phosphate, PRN, bloods will guide that, and potassium is probably the most prescribed medicine I prescribe for people who purge. So how much to give? Who needs it? So potassium you'll be familiar with, there's both Span-K and Chlorvescent. So Chlorvescent's not fully funded, which is kind of surprising because once upon a time it was. So now the mainstay for treatment, I use Span-K because it's funded, and tend to use Chlorvescent as required medicine. In phosphate, if required, that's the replacement dose there if needed. So as you can see, Span-K and Chlorvescent contain a different amount of potassium, which is going to be useful for when you're using it. It's good to do the maths and work out how much to use of these medicines. So a little example for you, because I've had to learn this when I started. It was like, I'd be getting these potassiums back. For an example, someone who's got a serum potassium level of 3.1. It'd be like, how much do I need to give them? So just knowing how much, if there's an immediate correction needed like that, I'd use the faster acting Chlorvescent, and knowing it would raise the serum level by 0.14, I'd say to my patient, right, you need 5 of those, because you're going to get you up to a level of like 3.8, and then from there on I can use as a regular dosing span K. And for example, I might start them on 4 a night and go up and down from there. Regular blood testing is the only way to go until I get real stability. But even then, purging patterns will often change, so it's regular blood monitoring until they stop purging, really. When it comes to referrals, main thing is to check with the patient, do they actually want help with their eating disorder? Ambivalence is a huge issue for most of my clients, and most of the people you'll see too. So they really need to want to engage with therapy, which is psychotherapy, and comply with regular medical monitoring. And if there's already a psychologist involved, it's really important to check with a psychologist if a referral to a service is actually a good idea. And secondly, discuss, do they want private or public? There are private eating disorder services in Auckland, and there is the public system. Waiting lists unfortunately exist in both systems, probably longer in the public system. If they are involved with a private therapist, they may need to forgo that private therapist, because if they are entering public system, they might be allocated a new therapist. So there's something to discuss with your patient. And medical monitoring actually remains in the domain of the GP or the referrer until the patient's been picked up by the public system, in which case it might still be with the GP, or it might be with the tupō clinicians, or both. So there's quite a lot of shared care. Helpful information to include in a referral is the rate of weight loss, eating pattern, fluid intake, compensatory behaviours, family history if known, and the usual stuff. For the under 18s, the referrals for the child and adolescent team come in either via an admission directly to Starship Hospital. So when they come out of Starship, straight away they go into the tupō system, or via the CAMS services. CAMS do most of the treatment with children, and they'll only refer the tricky, complex ones to tupō. So the message for the under 18s is refer them. You don't even, just refer anyone that sounds like they might have an eating disorder. For the adults, it's a bit trickier. For the over 18s, referrals to the CMH service, and they will just do a little screen and then check that it is going to be an eating disorder primarily. But unfortunately, there are entry criteria into tupō, which you'll see there. So we have triage meetings every week, and probably only 50% meet the criteria. So it's good to know the criteria, and sometimes it's just watchful waiting until the criteria are reached, and hopefully they're not reached, and that your patients will improve. So eating disorder therapy consists of psychiatric assessment initially, a medical assessment, dietitian assessment, and then therapy is psychological therapy. And depending on the kids will have FBT, which is family-based therapy, and the adults will have a range of other therapies. But ongoing involvement with tupō does depend on ongoing engagement with the clients, and engagement's not always there. A lot of people don't turn up. And ongoing medical monitoring. So the monitoring by patients, by GPs, the most frequent question I get asked is how often? And unfortunately the answer is as clinically indicated generally, and unless you've been told that the therapist wants monthly or something like that. And it's going to be, the rough guide is if they're losing weight, it's going to be frequent, and if they're not losing weight, a bit more stable. A bit like someone with heart failure, how often do you see someone with heart failure? It depends, eh? So it's roughly that. So what to do, it's very similar to the initial assessment that we talked about before. And bloods will be done a bit, there'll be some bloods you do frequently and some less frequently. The medical monitoring, again, if it reaches hospital admission criteria, it's for you to activate. Even if people are sending in some forms back to tupō, we sometimes don't see those forms for a few days, so we do rely on the GPs or the GP nurses to know when admission criteria are met. So the different types of EDs, eating disorders, you guys don't really need to know them, but it's good to know that these different types exist. And these websites are really useful. So thank you for listening.